Hi, everyone. Thank you. It's a privilege to be here, and I appreciate the opportunity to speak to this group on a topic close to my heart. So as an overview, I'll be speaking about the background and basic epidemiology of autoimmune diseases. You'll see the abbreviation AID throughout the presentation. I'll talk about how to study autoimmune diseases at the population level, with lupus surveillance as an example, and how to study, or why you would study autoimmune diseases as a group, and future directions. So to start with, I'm displaying a slide from cancer epidemiology. And I do this for a couple of reasons. The main reason being that I think as a society we come to expect and maybe take for granted the availability of population level statistics for certain groups of diseases. So on this one snapshot, you can see that in a period of time, in this case 1996 to 2005, we have a variety of site-specific cancers, male and female specific rates, and the red and blue indicate whether these diseases are increasing or decreasing over time. So this is a common type of data that you'll see publicized in cardiovascular disease, cancer, but we don't have that luxury in many diseases like the autoimmune diseases. And indeed, most autoimmune diseases appear to have received little or no attention at the population level. So here I have a bar graph. It's difficult to read the titles, but basically I'm showing on the left several individual autoimmune diseases. There's lupus, scleroderma, even the broad term autoimmune, where I searched the literature from 2000 onward to 2017. And over 17 years, if you look at two of the main epidemiology journals, we've only seen less than 30 or so articles for each of these conditions over that period of time. Whereas on the right, we have cancer and cardiovascular disease, and those publications are in the thousands. So clearly there is a gap here, and this is why we need to improve the data for these diseases. Just a real brief background, as everyone in this audience is of course aware, autoimmune diseases result from pathologic immune responses against the host immune system, rather than against foreign antigens. Autoimmunity is a relatively new field. In the 1900s, we started to hear the terms autoimmunity or horror autotoxicus by researchers who were advancing this principle, but it wasn't really until the 1950s and onward that autoimmunity as a basis for disease gained credibility. And so we're all on the same page in terms of terminology. I will distinguish between the terms autoimmunity and autoimmune diseases. So autoimmunity is the presence of autoreactive T or B cells, so cells in your body that may turn against yourself. But this is not always associated with pathology. Indeed, there's some degree of autoimmunity present in many individuals. For example, 13% of the general population is ANA positive, so they have a positive anti-nuclear antibody test. And this increases to 20% among women in the general population. This does not include just disease-specific categories. Often, autoimmunity in and of itself is harmless, but it can be a marker of future disease risk. So you can think of it as a biomarker, something like a cholesterol, where you know that higher levels may increase your future risk of a clinical outcome, but it's not a sure thing. Whereas autoimmune disease, oh, and one more point on that is that this has really spurned the field of preclinical autoimmunity. In the last 20 or so years, we've had some major advances to show that autoantibodies may be present in individuals over 10 years in advance of a diagnosis. So again, not everyone with a positive autoantibody will develop a disease, but it is a biomarker of future risk. Whereas autoimmune diseases, in contrast, are where autoimmunity progresses from benign to pathogenic. And at the bottom of the slide, I just have a simplistic paradigm of how we can think of this whole scheme. So you may start with genetic susceptibility, so individual underlying risk, and then triggers such as environmental triggers or maybe things like hormones may act early on to spur on autoimmunity, which may or may not then progress to clinical autoimmune disease. And perhaps the triggers for early autoimmunity may be the same as for later outcomes or progression. Perhaps they're different. And that's part of the challenge as epidemiologists to be able to disentangle. So here's a list of autoimmune diseases. It's by no means inclusive, but the main point here is that they can be grouped according to organ system. Some are organ specific and some are systemic. There are over 24 disorders that are in the mainstream considered to have an autoimmune basis. It's not always clear how these can be classified, but over 80 diseases have been suggested to have some autoimmune basis. The symptoms vary widely, as I'm sure you all appreciate. This can lead to great difficulties in the diagnosis and treatment of these diseases. And again, to reiterate, they're often grouped or studied according to organ system involved or clinical subspecialty. One of the leading features of autoimmune diseases as a whole is that they are female predominant. So there's a stark, there's a stark female predominance, which can be seen in the top part of this chart, where the majority of autoimmune diseases have more female patients than male patients. And the ratios extend up to 10-to-1 females to males, with autoimmune thyroiditis probably having the highest female to male ratio. In the yellow band are the few diseases that are said to have a 1-to-1 ratio, meaning equal male and female patients. And then there are a couple of examples at the bottom would be ankylosing spondylitis, where males are the predominant patients. So the theme of why there are these major sex disparities is a really important one to related to autoimmune diseases, and it's a big challenge to figure out why this occurs. Another aspect of autoimmune diseases is that they may strike at any point in life. The top of the chart shows a couple that are childhood onset diseases, juvenile rheumatoid arthritis and type 1 diabetes. There are lots that are what we would consider mid-adult onset, and then some that are late adult onset. And when we talk about disease burden, it's really important to, again, think of the set of diseases together. So in 1997, a group, and I believe Dr. Rose was the lead author of this project, there was a seminal review that took 24 established autoimmune diseases, and they did a really thorough, systematic review of the literature. And this was a really first of its kind effort. It may seem like a no-brainer to do this type of work, but in the field it was a major advance. So the outcome of this review, one of the main findings was that 1 in 31 persons in the United States, or 3.2% of the population, is afflicted by an autoimmune disease. Several years later, I had the opportunity to update this data with Glinda Cooper, and we reviewed 29 autoimmune diseases, 1989 to 2008. In contrast to the previous study, this included many regions around the world. And in this update, we estimated that the prevalence worldwide of autoimmune diseases is 7.6 to 9% of the population. So it does, in fact, affect a lot of people. And the chronic nature of these diseases, which is often disabling, results in substantial costs in terms of quality of life, medical care utilization, and direct and indirect economic costs. The effects on mortality and morbidity are quite high, despite the common perception that these are relatively rare diseases. And the combined mortality from autoimmune diseases is actually hidden. And what I mean by this is that most people are probably not aware that autoimmune diseases as a group rank among the top 10 causes of death among females. You in this room probably might appreciate this more than others in the community, but you're probably wondering why this is not a mainstream statistic. And the reason for that is because the main cause of death rankings have a lot of methodological issues that don't account for groupings such as the autoimmune diseases. So for instance, in the US, the National Center for Healthcare Statistics annually identifies the top 10 causes of death. And the candidates for the leading causes are based on a subset of 37 rankable categories. The autoimmune diseases do not rank well in this because 16 of 24 of the diseases are included in non-rankable categories, and 8 of 24 are absorbed into broader categories based on the organ system of involvement. And in addition, to further compound this, are coding limitations. So for example, in lupus, which is the field that I'm mostly involved with, we have noted significant misclassification and underreporting of lupus codes in population statistics. For example, one study showed that 40% of death certificates from lupus patients did not mention lupus on the death certificate. And there were specific factors associated with the lack of recording, including older age and lack of insurance. Another question that often is asked is whether autoimmune diseases are increasing over time. And to this, the answer would be yes, no, and we don't know. So we don't know for many diseases because the data are completely lacking. However, we actually see two different trends in the diseases that we do have data for. So here's a snapshot of data that I compiled in the 1990s in the United Kingdom using population-based data. We can see on the left that rheumatoid arthritis and multiple sclerosis are decreasing over time during this 10-year span. And on the right-hand side, we see that autoimmune thyroiditis and type 1 diabetes are increasing over time. With diabetes on the bottom right-hand corner, it's further interesting because it's an age-specific increase. Not all age groups are increasing. So this is important to understand, obviously, are interventions working if they're decreasing, but also in terms of risk factors. So one question is, what is driving the reduced risk over time of RA and MS? And are there modifiable risk factors that we can institute? And hopefully those risk factors that are decreasing RA and MS are not the ones triggering the increases in type 1 diabetes and autoimmune thyroiditis. So those are questions we need to pay a lot of attention to. And the general theme overall that we, I think as most epidemiologists and scientists in the field feel, is that the causes really relate to genes and in the environment and their interactions. So a couple points on this. Across the autoimmune diseases, we know from things like twin studies that not all of the diseases have the same contribution of genetic risk. So some have high levels of twin concordance and some have low levels of twin concordance, but the bottom line is that they all have some degree. The environment, we can see from the previous slide that we suspect there are environmental factors that are leading to these temporal increases or decreases. But in addition, if you think about combinations between genes that are specific for individual diseases, which we would call specific genes, or pleiotropic genes that may be responsible for autoimmunity, but not a specific clinical state. If you throw those in combination with each other with various risk factors, you can see at the bottom what we call the mosaic of autoimmunity. So in other words, it's a specific combination of common factors that will lead to a different clinical phenotype. And one last idea to plant is that we also feel that the Lifecourse approach is extremely important when we're studying diseases and environmental factors. So what happens across the lifespan? I put this picture here because you may think of a typical patient, perhaps if it's a late disease, onset disease, you might think of the top picture. But what's happened in childhood or earlier life stages, perhaps around the reproductive years or in menopause, that may lead to setting the stage for risk across the lifespan. And one of the reasons why I want to mention this in particular is because in rare diseases, it's hard enough to identify exposures that are relevant, but for remote exposures, temporally, it's even harder. So by aggregating diseases in logical ways, it can really improve our ability to detect obscure associations. So how do we study autoimmune diseases at the population level? And by population-based, I mean having a specified defined population denominator. And this is important because we are not restricting data to convenience samples or to hospital-based samples, which ultimately can lead to unbiased or misleading results. So the example I'll draw from is my work with the MILES program, the Michigan Lupus Epidemiology and Surveillance Program. And so a note about public health surveillance, which is the basis for the MILES program. Public health surveillance is really the key to understanding the etiology, risk, and prognosis of disease, as well as prevention and intervention outcomes. There are two main types of surveillance, passive on the left and active, which I show on the right. So passive surveillance can be thought of as off the rack, the use of existing or routine data sources, such as national healthcare records. In places like Europe, where there are national healthcare systems, this type of surveillance is often easier to employ than in the United States, where we have a much more fragmented healthcare system. And the big advantage of passive surveillance is that it enables large size populations to be studied, so large sample sizes, and it's at relatively low cost. But the big disadvantage is that you get what you get. Whereas active surveillance is tailored. You collect data customized to fit the problem at hand. So the major advantage of this is that you can really customize a detailed phenotype that is relevant for your question. But of course, this is extremely resource intensive. So it's part of the reason why active surveillance is not routinely done. The Centers for Disease Control, the CDC, back in the early 2000s, wanted to learn more about lupus epidemiology. So they have what's called the National Arthritis Action Plan. And part of the action plan was to improve data and health statistics on arthritis and allied conditions, and lupus falls into that category. At that time, in the United States, the largest epi studies of lupus had no more than 300 cases. Most of them were in the hundreds or lower, and they were based on very homogeneous populations with lacking diversity. So the CDC instituted the National Lupus Registries, of which Michigan was one of the prototypic sites, along with a sister site in Georgia out of Atlanta and Emory. After the Michigan and Georgia sites were established, about 5 years later, additional sites were added in Manhattan and San Francisco, as well as the Indian Health Service. So this was an extremely unique project in not just the field of lupus, but in rheumatology, and I would say autoimmunity as well. The phase 1 was a Miles registry where we constructed a registry of lupus patients in our region. The primary aim was to estimate the incidence and prevalence rates of lupus during a defined time period. And by incidence, we mean the number of new cases diagnosed, which is a measure of the risk of disease, as well as the prevalent cases. Prevalence means the number of existing cases in the population, which is a measure of the burden of disease. We studied this in southeastern Michigan. So in the southeastern corner, you may be able to see a pink box, but basically the population density in these two counties is quite high. It contains 25% of the Michigan population, or 2.4 million people, a diverse population with a range of sociodemographics. And so the challenge that we had was, in this population of 2.5 million, how could we go out and find and validate every lupus case? So then we could establish population rates. To do this, we modeled our activities after cancer registry activities. And we were fortunate in the Detroit area to have a site that's a member of the SEER Cancer Registries, which is part of the National Cancer Network of Cancer Surveillance. We next had to partner with our state health department. So this is a key step that occurs in active surveillance most of the time. And what this means is that through this partnership, the academic partners, like us at the University of Michigan, can provide the lupus or clinical expertise, whereas the state health partners have the public health authority to conduct the surveillance, and they can designate agents to conduct the work of the surveillance. Excuse me. So this brings about a host of regulatory issues. Sir Richard Dahl, who's a famous epidemiologist from England, said, "Now it is becoming horrifyingly difficult to get hold of epidemiological information, and I can see great difficulties for the epidemiologists of the future." And that was really borne out in our work. So to give you an idea of the complex regulatory structure, I've put a flow chart, not to bore you with the details, but the main points are there are many stakeholders and components along the way. The first is having the federal lead, the CDC. Next is having the state health department. And then in the course of all the work and engaging academic partners and hospitals and health systems and the cooperation of a host of entities, throughout the course of that, we have to really engage our partners in a way that can be effective and that we can, of course, have the regulatory authority to handle all of this data. Because when we do the case finding, we have to go out into the community. In this case, we had multiple sources of case finding. We went to all the hospitals, specialist providers in the area, and at the end of the day, we can look at the overlap in cases between these providers. At each of these providers, we have to do detailed case with is the American College of Rheumatology, or ACR criteria. So you're considered to have lupus if you meet 4 out of the 11 criteria listed here. And again, I don't expect you to read the detail, but the main point is each of the 11 criteria has subcriteria and a lot of caveats. So for instance, if you have a low white blood count, is it caused by a drug and not because of lupus? So to distill this into a systematic study in the population of whether you can validate a lupus case or not is challenging. We had to come up with a system where we had over 200 data elements to confirm or refute a diagnosis. Just a quick snapshot of our work is presented here. And then coming up with diagnosis dates and onset dates, that's a whole other challenge, which causes a lot of time and resources. At the end of the day, in order to come up with our registry, which led to incidence and prevalence estimates, we had to screen over 13,000 records in the area. And as a prototype site, the first half of the project, I would say, was really the infrastructure building and the relationship building. And this took 10 years from start to finish, from the very beginning of instituting this, the first 4 or 5 years of infrastructure building, and then the actual data collection and validation, and then reporting. We found eventually we distilled this down to over 2,000 lupus cases that we confirmed in the area. And as another way to look at the time frame, this was truly a labor of love. My colleague, Dr. Marder, and I had 5 girls between the two of us during the course of this study. So we are in a women's health, of course, but we did think it was worth it because we came up with results that really have been pretty revolutionary in the field in terms of not just knowing the numbers, but looking at age and sex-specific patterns and race-specific patterns. So here I have a graph where the purple curve on the top represents black women. And the next curve, the lighter bluish purple, are white women, and then males underneath. So the point to this is not only that black women have the highest risk, but their risk is peaking in the 20s. That's what we talk about as the reproductive years. We often think of lupus as a disease of reproductive age. But for white women, the curve is shifted towards the right. So their risk isn't happening until a little bit later onward. In some work I've done in the United Kingdom, we've shown that their risk actually peaks in the 50s, around the time of menopause as opposed to the reproductive years. So this can also feed back to design of etiologic studies. If we want to know what's causing lupus, is it fair to look at the same time periods for black women and white women and others? If we want to identify risk periods or risk factors, perhaps in black women we have to be looking at childhood or their teenage years, and for white women perhaps in their 20s. So that's the type of thought that goes into these patterns and how to interpret them and what to do with them. Next, looking at prevalence, we show again that black women experience the highest prevalence, but what we did not know previously was that differential in burden, and again, you can see across the lifespan, the area under the curve between the black women and the white women is really stark, and that means over a lifetime experiencing these decreases in quality of life and all kinds of other costs associated with the disease. And these types of data, I'm pointing out that in our region, and I think similarly in Atlanta with their site, these really had a big local impact. We were able to show that 1 in 537 black women in Michigan has lupus. Again, this means it's not a rare disease, at least in this subset of the population. And this can feed into definitely lupus awareness, but perhaps things like screening activities that are important to screen for things like subclinical kidney involvement that might be happening in early lupus that may not be detected clinically. And then tying together the data from the Michigan and the Georgia sites, we then had the basis to generate what we consider the first national estimates of lupus. And the data from the other 3 sites are going to be published probably any day now or probably within the next month. But from our 2 prototype sites, we showed similar incidence rates and prevalence rates within a 1/10 of each other. So incidence of 5.5 per 100,000, prevalence of 73 per 100,000. And we were floored by the comparability of these results. But the bigger point is that because we used the same methods and worked collaboratively with that site, overseen and in cooperation with the CDC and our health departments, these comparable methods lead us to be confident in the results and being able to extrapolate them across the population. And this has helped feed into policy ultimately. So the population data, of course, can be used to support policy making and research and funding priorities. And having this done in such a rigorous fashion really improves our ability to do so. And I've put a snapshot here of the first ever National Public Health Agenda for Lupus, which I was privileged to be a member of the committee that derived this. And it fed off of, in large part, the registry efforts that we had. So to wrap up, going back to the collective approach to autoimmune diseases, again, autoimmune diseases have usually been studied as separate entities, each disease individually rather than as a group of disorders. So why do we want to study these as a group? So the first, I'd say, is purely practical. Utilization and extension of infrastructure developed in other disease conditions is efficient and cost-effective, and we can use something like the National Lupus Registry efforts to model after for other diseases and hopefully to piggyback on, making it a win-win. Basic principles of one autoimmune disease are relevant to others. The recognition of both common and divergent etiologic, environmental, or genetic risk factors is important. And clustering of certain autoimmune diseases has been shown to occur within individuals and families. Now, anecdotally, in years past, we have heard that clustering happens. But some work I did, mainly in the United Kingdom, has shown that there's actually certain patterns of clustering or coexistence. So for instance here, I've shown in the yellow circles that rheumatoid arthritis, type 1 diabetes, and autoimmune thyroiditis cluster, and by that I mean if you have one of those in yourself or in your family, then you and your family members are at greater risk of being diagnosed with one of these other conditions in that triad of diseases. However, MS, which is in the blue circle, is in the opposite direction. We've shown in that work that if you have rheumatoid arthritis, you actually have a decreased risk of MS compared to the general population, and vice versa. So that's important in and of itself to understand risk factors, but it can also be used in things like pharmacoepidemiology. So for example, I bring up the point that in years past when the TNF inhibitors first were coming to market, there were reports of MS and demyelinating conditions happening among those treated for RA with the TNF inhibitors. And at the time, there was a lot of, the sentiment tended to be that if you have rheumatoid arthritis, you're more likely to have MS anyway, just by virtue of having an autoimmune disease. But the fact that we showed the inverse relationship actually makes those reports of MS in the TNF inhibitor-treated patients more alarming, and it helps us to be able to interpret that. And lastly, innovative prevention and treatment strategies applied to one autoimmune disease may be useful in others. So I've brought in one last example of an innovative design. Some of you may have heard of basket studies. These have been starting to get used in the cancer population. So for instance, this would be a scenario where you enroll patients with different cancers in the same trial if they have a common genetic mutation. And my thought is that the autoimmune diseases are a naturally amenable group to this sort of study design potentially. Maybe if we have clearly defined biologic pathways in common between diseases, perhaps it makes sense to get away from the single disease clinical trial model and to move into some of these more innovative directions. So I'll close by saying, repeating a quote from Joe Biden recently, that the only bipartisan thing left in America is the fight against cancer. And I would extend that to say really any health issue should be bipartisan, and by coming together and bringing a common voice to the autoimmune diseases, hopefully we can get that more on the agenda. Thank you. So we didn't see that exactly. I guess a couple of points would be, the first thing is when you have the ability in a large-scale database such as that to use the same methodology year on year and across diseases, you don't expect to be confounded by those sorts of things because you're comparing apples to apples. And the other point is we were concerned about things like the bias of if you have one disease, are you just more likely to have a second disease detected, or what we would call consulting bias. And we attempted to get around that. Essentially what we showed was that because the directionality of diagnosis, where for instance, if you have rheumatoid arthritis first and then are diagnosed with thyroid disease or vice versa, we saw the same patterns. So we feel because of a number of reasons, but empirically because of the data and being able to exclude things like consulting behaviors, which gets into a lot of methodologic detail that I couldn't get into here, we feel like that was not in our study a major factor.
Great. Well, thank you, Dr. Summers.
Thank you.